I'll be discussing on laser atherectomy. So what is Elsimer laser? It is the light amplification by stimulated emission of radiation. So this is the console and this is the catheter. We have to have a warm-up period of 5 minutes. We have to have a calibration of the catheter outside the body before putting it into our system. So we have to wear protective goggles and we have to calibrate the system. And this light spectrum belongs to the ultraviolet range, that is 308 nanometers. The mechanism of action, it has light pulse, sonic wave, and also vapor bubble. The light pulse, it has disruption of the molecular level, and it also breaks down the atoms. And the sonic waves also helps in breaking the calcium, and also the vapor bubble also it amplifies the signals, and within the system we have to give saline that forms vapors along with the natant gas, and it forms bubbles. It depends upon the energy delivered and also the frequency. So as the frequency and the energy delivered increases, then vapor bubble increases in size, and it causes the disruption of the molecules, and it causes luminal increase in diameter. And also this is the catheter. The cross-sectional area shows it is an optic fibers that transmits the light. So for the success of the laser, the 5 A's is needed: selection of the patient, size of the catheter, it should be less than 2/3 of the artery diameter, and the settings, especially the fluency and the frequency, and a saline flush is needed. In some cases, when we need to break the calcium, we can give that is 50% contrast flush also. And also the advancement of the catheter should be very slow. That is less than 1 millimeter per second advancement is needed for good result. So this is a case, a 75-year-old male who has hypertension for 8 years, came with chest pain and breathlessness in the month of March, and he's already had a PTCA to RCA in 2014, and a check angio done in 2019 showed a patent stent in RCA. By that time, he developed bilateral renal artery stenosis, and both were stented. So this time, diagnosis of acute inferior wall MI was made, and also he had creatinine of 1.4 milligram per deciliter. So we proceeded with the angiogram. They showed a 100% occlusion of the RCA, that is ISR, with a thrombus. And also the left side system also had %90 stenosis of the OM. So we decided that we will proceed with the Elsimer lesion, assisted PCI to RCA, and we couldn't cross the lesion with the BMW wire, even with the help of a microcatheter. Even we couldn't pass a whisper wire. And in last, we took a Gaia wire, and also with the help of a contralateral injection, we have done we were able to pass the Gaia wire. Then the ELCA was advanced. Initially 40 fluency and 40 frequency, and next 60 fluency and frequency was used, and then we were able to pre-dilate with the 2 millimeter balloon thoroughly, and also 2.5 millimeter balloon thoroughly, and we were able to deploy a 2.5 into 40 millimeter DES distally and 3 into 48 millimeter DES in the proximal segment. This is the pre-intervention image, and this is the post-intervention image. So what is the indication of ELCA? We can use ELCA in instant restenosis, CTO lesion, that is wire-crossed balloon non-crossable lesion, balloon non-dilatable lesion, long lesion that is greater than 20 millimeter, moderately calcified lesion, austere lesion, eccentric lesion, and occluded venous graft, and also in the presence of thrombus. Where it is contraindicated in acute angulation greater than 45 degree, coronary dissection, unprotected left main we have to use with caution, and also in heavily calcified lesion. So with the help of ELCA, we will be able to achieve a good result, and also there is a risk of perforation and also a risk of rupture of the vessel also. So we should know when to stop this, and now I stop my presentation. Thank you.
Thanks a lot, Dr. Aruna. We come to the last session of the day, and we'll put our hands together and welcome Dr. Jayalakshmi. She'll be giving the presentation on robotic PCI. Kindly do remain now, because we have the very, very important part of this. One of the most keen points, the quiz will be happening. So please do wait, and we'll see who will be the first and the second out of the 4 sets who have been selected. Thank you.
Good evening, everyone. I am Dr. Jayalakshmi. I thank Dr. YVC for giving me this opportunity. Today, my topic is about robotic PCI. So, it is recently emerged novel modality in interventional cardiology, aiming to address both the occupational hazards for the operator alongside procedural quality and safety improvement for the patient. So, first human application of this robotic PCI was taken in 2006. And the first FDA approval was achieved in 2012. And it's the CorePath 200 system. It was the first generation robotic system. And the second generation with much more advanced features was launched in Jan 2017. And it's called CorePath GRX. It contains a third joystick, which is useful for manipulating the guide catheters. It also contains Technique Smart Procedural Automation. It's for deciding the stent length necessary for the stent coronary lesion. So this is the diagrammatic representation of this robotic system. It contains 2 arms. One is the robotic arm, which is located in the bedside of the patient, and the other is the interventional cockpit, or the console, which is located in the console or behind a radiation shield. And in this robotic arm, there is a single-use cassette through which the hardware system are loaded and manipulated. And it is manipulated by this is the console. It contains 3 joysticks. One is used to load the guide catheter and manipulate the guide catheter. One is to manipulate the guide wire, and the other joystick to advance the devices, balloons or stents. So this robotic arm is connected to the control console via cables. So this is the Corundus CorePath 200. This is the first generation. Corundus CorePath GRX. This is the second generation. So some nursing personnel must be there in the cath lab to load this cassette with the hardware. This is the loading of the cassette with guide wires and devices, and the interventional cardiologist sitting in the interventional cockpit managing or manipulating this guide wires negotiation. This is the timeline of development of robotic PCI. In 2006, the first human robotic PCI study was done, and in 2012, the CorePath 200 has got the FDA approval. In 2017, the second generation got approval. So mainly, the aim of this robotic system is to combat the occupational hazards associated with the radiation. So radiation exposure damages are the following, like increased risk of brain tumors. Interventionalists have increased risk of developing left-sided brain tumors and increased risk of premature cataracts. And also early vascular aging is also seen. Apart from this, there are also orthopedic damages like increased risk of orthopedic injuries. So in order to combat this, this robotic PCIs is very helpful. And we all know that interventionalists have a professional lifetime risk of 0.4 to 1.5% increased chances of developing carcinomas when compared to the general population. So by using this robotic system, radiation shielded workstation reducing the radiation exposure to the primary operator. And it also reduces orthopedic injuries by preventing us to wearing heavy lead aprons. And also, because the monitor is situated close to the interventionalist, we can see the monitor or angiographic videos at a close proximity, which enhances the estimation of lesion length and lesion severity more accurately. It's also important for the nursing team, which is located inside the laboratory, because at various positions, that is 1, 2, 3 position, the person standing in the first position has 18.6 microsieverts of radiation exposure, whereas the person standing at the third position has 0.54 microsieverts receiving of radiation. So by using this robotic system, we can also reduce the radiation exposure of the nursing team, which is situated inside the lab. And these are the advantages of manual PCI and robotic assisted PCI. When compared to manual PCI, it has close proximity, ergonomic visualization, and also precise point and short predictability, and submillimetric measurement of the lesion length because of its submillimetric ability for navigation. And also 1 mm precise positioning. Positioning is more better with the robotic system than manual PCI. And fixated devices during the deployment. These are all the advantages. So by precisely measuring this lesion length, we can also save number of stents placed in an individual. But there are some limitations in the current robotic PCI technology, which requires manual conversion at some point of time. So it's incompatible for using devices such as IVUS, ROTA, OCT, and inability to manipulate multiple stents or catheters at the same time. So bifurcating lesions that to do with robotic PCI is still not possible. And technical failure in severe tortuous anatomy, coronary dissections. Here there is high chance of turning into manual PCI. And sometimes in primary cases, it is difficult to do with robotic PCI because of lead time required to set up the robotic system. And there are when in no reflow, then we have to use microcatheters, which are not compatible with the robotic system. And in unstable patients who might require manual attention at the bedside, as they may decompensate at any time on the table, requiring TPI or CPR, then it's not so much useful. And coronary perforation necessitating pericardiocentesis. For this also, some manual attention is needed. And these are the trials which shows advantages of robotic system. Mainly, clinical procedural success is 97.6%, device technical success is 98.8%, and no device-related complications. And secondary endpoints are 92%, 95% reduction in the radiation exposure to primary operator. And this is another study, CORA PCI trial. This is mainly the use of robotic PCI in complex PCIs. And our experience with the robotic system, our Dr. YVC sir, he's a pioneer in doing the robotic PCIs. We had a wide variety of cases which were done with robotic PCI. So we have tackled CTO ostial lesion, this manually assisted robotic PCI, and calcific mid-LED lesion. Also in tortuous LED lesions also this is useful. Also in occlusive ISR, here also robotic system is used. And finally, for the first time in the world, physiology-guided PCI was done and published by Dr. YVC sir in European Heart Journal case. This is the futuristic robotic PCI with innovative physiology optimization. This is the first time in the world who has done physiology guided PCI. So here we have mid-RCA lesion. Physiologic significance is estimated by calculating RFR and FFR. And then PCI was done. This is the OCT which was done manually, showing the good result.